Welcome to the Med-Legal Greenroom. I am Sam Frentzas, co-founder of the Driving Force Company. Today, we are joined by Dr. Jay Kumar, a board-certified anesthesiologist, interventional pain medicine specialist, and founder of Spine and Pain Specialist of the Carolinas in Charlotte, North Carolina. A former clinical associate professor at Duke University School of Medicine, Dr. Kumar specializes in advanced pain treatments, including spinal cord, dorsal root ganglion. Say that word for me, Dr. Kumar.
Ganglion.
Ganglion and peripheral nerve stimulation. His practice is focused on helping patients find the true source of their pain and providing innovative solutions that restore function, improve quality of life, and reduce the reliance on opioid medication. Please join me in welcoming Dr. Jay Kumar. Welcome.
Hi, thanks for having me. How are you?
I am doing great. Thank you for being on here, taking time out of your day so we
Yeah, of
can
course.
discuss some of these topics. I think we're going to go over, and I want to make sure I have this correct, peripheral nerve stimulation and neuromodulation, a
Yeah,
novel and rapidly expanding treatment approach for patients with chronic pain.
yeah, absolutely. So neuromodulation, well, I mean, if you want, I can go through the basics, but
Yeah, so
it was
please.
invented in 1952. Um, the back in the day analogy for what the treatment option is, which has nothing to do with what it is today, but back then, 1952, was a TENS unit. And so, what does a TENS unit do? It's a box that you can get from Amazon, has some wires and has some stickers. Let's say you had knee pain, you put the stickers on, turn the box off, turn the box on, creates a little mini vibration massage sensation, mentally distracting it. In theory, the knee pain should subside a smidge. Turn the box off, pain comes back. It used to be thought that there was like a what's called a gate theory. The higher stimulus over the that overpowers the highway to the brain takes over, and that's what you feel more. So I used to tell patients to help explain if you came in my clinic, not you, somebody with a broken elbow, and then God forbid goes back to their car and jams the left finger in their door. The left finger is going to hurt 50 to 100x more than the broken elbow. Brain focuses on the higher stimulus. So using that concept, everything in life we have gets better and better each decade, right? Across the board. So we made the frequency, or the fancy smart people did, made the frequency so high that the brain and spinal cord feel a distraction buzzing. But the modern day analogy is a dog whistle because you as a person do not, because the frequency is so high. So there's something called chronic sensitization. There's a whole separate topic, but a bunch of pain syndromes where they can't get out of this chronic pain cycle because they're so chronically sensitized from all the pain signals. So you need a way to help break them out of it. Initially, it was invented, and the data supports the best still to this day for neuropathic pain. So any numbness, burning, shooting, tingling, pins, or needles, and of those are buzzwords for neuropathy.
Yeah.
So the main indications from the FDA, based on data evidence, is diabetic painful neuropathy. You can have the most best patient on the planet and best A1C, best regimen, everything, but you could still unfortunately develop neuropathy. It's debilitating, especially at nighttime. You feel like your feet are on fire. So that was the newest FDA indication. Failed back surgery syndrome, meaning you've had back surgery but still have back pain. Post laminectomy syndrome, pain syndrome, which is having a history of laminectomy, and complex regional pain syndrome, CRPS. Again, that's a whole separate topic, but there's two separate types. And some of these patients, without this treatment, their life would be completely not the way they would want it to be, put it that way. So it doesn't mean it's a blanket treatment for everybody across the door that comes through the door, but for the right patient, going down the algorithmic step by step, only doing what you need to improve quality of life. This is a incredible option because you can't surgicize neuropathy. And if a patient already had surgery, then that's already doing that option. So doing that again isn't statistically going to improve that. So this is another modality or toolkit in the tool belt to use for the right patient. There's two types of neuromodulation. There's spinal cord stim and then peripheral nerve stim, which is what you brought up. And then depending on what you want to discuss, we'll go into details.
Yeah, absolutely. And ironically, I have a TENS unit that I use after I play golf. So funny that you say that on my
Yeah.
lumbar spine. So it does, yeah, I don't know if it's psychological, but whatever it is, I'm glad
It's a
that for
mental
the
distractant,
moment
yeah.
it does.
Ironically, even though the modern day SCS and PNS or peripheral nerve stim and spinal cord stim, the acronyms are SCS and PNS. The modern day ones are silent, or the medical words paresthesia free.
Yeah,
Um, Ironically, 10 to 15% of the population prefers the buzzing, but nobody knows until you try it.
that's true.
Yeah.
So then let's talk about the treatment. So how do you select the right patient, for this treatment option? Let's dig into that
Yeah,
mind and
that's a
get
great
that
question.
answer.
So, you can ask 10 people and five may give you different answers, but I'm a big believer of walking into the room, and it's my job to make sure I know as a physician what options they can and cannot have. I am not the decider. Unfortunately, it's bigger than me. It's insurance, whether it be insurance A, insurance B, insurance C. And what I mean by this is not because I care. It's not a negative thing. It's my protection way for the patient. If I walk into the room and I tell them five things that are invented, but their insurance, for whatever reason, is not my fault, doesn't approve it, all I did was bring their hopes up just to drop them like a sack of bricks. And then you always want what you can't have, right? So then you get miserable based on that. So, joking aside, I genuinely think it's important to walk in and know what options they can and cannot have. So that's number one. So what I mean by that is peripheral nerve stim, the biggest hurdle as we speak today is insurance coverage. Most recently, a few big things happened, which also support how good of a treatment option it is. Um, Most recently, as a few months ago, it's all public information. Aetna is the first commercial insurance company in the country to approve PNS for certain targets. It's been approved by Medicare, Medicare Advantage for quite some time, many years. So that's huge because when
Yeah,
one starts, in theory, based on the data, they
yeah.
don't have to, they can do what they want. It should be trickle down effect for the remainder, and that can open up a large more patient population that needs it. Um, the other big thing that occurred in the news is Medtronic, one of the giant medical device companies of the world, not the United States, has recently acquired Sprint SPR. Sprint SPR has been around for before 2012. Maria Bennett is the incredible genius behind inventing the device. Um, I had the opportunity and honor to be able to work with this device and use it and understand how to bring this into my treatment algorithm for low back pain that stayed in the low back region, not like sciatica. And I can go into a whole bunch of details about the data, but they recently got acquired by Medtronic. And it's again public news information for like 650 million. Again, based on the data. A lot of their data started in 2012 based out of the Department of Defense. Essentially, the data shows that if a patient responds during the 60-day treatment cycle, even though the stimulation lead itself gets pulled out after 60 days, the patient that responds during that time frame can have delayed effect or sustained pain relief for up to a year based on the data. And about 70% of patients are responders based on the data as well. And they just released a multi-center randomized data set too that they're going to discuss at the annual conference in July.
That's pretty good. And I think right now, and I can honestly speak for you and pretty much every doctor that's out there, right? The common goal is to avoid opioids
Of course.
for a multitude of reasons.
But yeah, numerous appropriate reasons.
Yes.
You have to also factor in the patients that unfortunately or whatever that unfortunately need the medication.
Yeah.
It is affecting them in a negative way, but so that's why I add that.
No, absolutely. So, what is the future of interventional pain medicine?
Yeah. Well, after 2018, the common goal across the United States, multitude of specialties, was to decrease unnecessary opioid use. This gets further backed up by the government when you see things that started in 2025 and 2026 called the No Pain Act, where hospitals will get an increased 6% reimbursement for using non-opioid acute pain management techniques that also prevent readmission after surgery. And 6% may not seem like a lot, but that's a lot.
There's a
And
lot.
that's meaningful. And the government wouldn't do that if it wasn't meaningful to begin with for numerous reasons that we all can assume. So all of these things, so the government's aligned, the physicians are aligned, the mid-levels are aligned. It's just a matter of continuing the education that, it used to be where we wanted to, I hate to say this, but like kick the can down the road. The patient would come in and say, I had 5 steroid injections or 5 cortisone injections. Well, we don't do that anymore. There used to be a concept of a series of 3. You do a boom, 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 2 weeks apart. We don't do that. Now, for numerous reasons, the data doesn't support it. Medicare doesn't let us. Guidelines say it's not useful and that you don't get reimbursed for it because it's not appropriate. So the goal is to try to treat the source of chronic pain symptoms. Band-aids or oral medications of whatever flavor are temporizing, and they're meant appropriately in an acute situation. We have numerous types of different acute pain meds now. For example, Journavx. It's recently approved by the FDA for mild to moderate acute pain, and acute post-operative pain. Actually, recently got that label. Um, let's see what else. But yeah, the common goal is to not just keep doing the same injection after again and after again. Try to use imaging, incorporate physical exam. I have to examine each patient. I don't just talk to them. Or assume they have, sacroiliitis or lumbar. You have to do an exam, use a reflex hammer, use imaging, explain to the patient what's going on. If you try a injection, you don't do that same injection 4 times and hope for the best. You do it once, you see their response, and then you talk to that patient and say, you know what? You're not following conservative treatment. I really would like you to go chat with a surgeon to go have you hear what that rest of the menu is. You're the one that decides, but it's important. And so here where I am in Charlotte, I mean, I have the luxury to be going in tandem with 2 of the largest spine and ortho groups in the country. Carolina Neurosurgery is the largest neurosurgery group in the United States of America, and they are right there next to me. And Ortho Carolina is, to my understanding, the largest orthopedic hospital in the Southeast, to be honest. And so, with those ortho spine doctors, so I, as a private practice, it's really important that if I'm seeing very common patients, that I'm doing things in tandem with them, not road blocking, aka we all have to work in the sandbox, but it's my duty to also know when to progress a patient's treatment. So it's becoming more, I guess, to solidify the answer, multidisciplinary, back to how it was originally anticipated to do, or meant to be, rather.
Yeah. So what, and I know you've kind of covered this, but I want to get a little specific and pull that two gold nuggets out of you. One is for doctors. What can you offer and say? Because look, you've been highly regarded. I've spoken to people and they said great things, and not to your cholesterol's high enough, you don't need your ass buttered, as I say. But what piece of advice you can offer
That's funny. I
to
like that. I'm going to steal
doctors?
that from you, by the way.
Absolutely.
I honestly, I would say that answer to that question is interventional pain is not just quote pain management. We used to do quote pain management. However, the goal here is now way bigger. It's interventional pain. So if you look at my shirt, I mean, I'm partly joking just to help, but at the same time, to answer your question, yeah, the field has changed. It's way more advanced than it was back in the early 2000s. And clearly what we did then didn't work because now we have not just one, but 2 opioid movies, one on Netflix, one on Hulu. Actually, they're pretty good. You should watch them.
No, and I love it because I do have a friend of mine that's actually an oral surgeon that wrote a book. What every parent of an adolescent needs to know about opioids, because he pulls wisdom teeth without opioids, because that's when they first get introduced. So I'm very, very big on that.
Actually, I will say firsthand for myself. Oh, wow. That is the first time back when I was in high school. That's when I got my 4 out. Wow, you're so right. That is
Yep.
the first time. I don't know where the bottle went.
Yep. And I'll,
It's
I'll
it's
send you
some.
the copy of his book, Dr.
Wow,
Jim
that's
Babiak.
so on point. Yeah.
Yeah, he was spot on. And what advice can you give patients? I know they get so many different things, but if you
Yeah.
can help them through journeys, questions, what advice can you offer?
Best advice. Advocate for yourself without a question of a doubt. You have to now more than ever before. If you're not happy with your provider, there's no feelings. You do what you want and you find somebody else. You need the physician needs to be able to talk to you. You need to explain your issue. They need to hear you. Um, what happens is, to be honest, the reason I have a practice and a job and patients that come see me is because I spend time and I talk to the patient, I figure out what their issue is, and then look at their imaging and find the matchup. If I get a see-through picture for any patient and I just, oh yeah, I look at the thing, treat that, you end up looking at the patient, they don't have any sciatica, it's all there. Just because it shows it doesn't mean you have to be symptomatic. So you have to listen, talk to the patient, do an exam, like very basics. But unfortunately, the system itself, I feel like, has made the process difficult. And it's a matter of finding the right, you have to mesh with your doctor. And if you don't, find another one. There's no harm, no foul.
And I agree with that. So everybody click the link below. I want you to check out the website of Spine and Pain Specialist of Carolina. See what Dr. Kumar is about. I know there's people that travel from different parts of the country to see him. So if that's the case, believe you me, it is worth the travel and worth the talk. So click the link below, investigate. Dr. Kumar, thank you for taking the time out today,
Yeah, no problem.
answering
Our
these things.
our social media handle on across everything, TikTok, Instagram, everything is at Pain Doctors. It's pretty got it in 2016.
And I'll put that down there as well. Thank you
Thank you.
so much for being on the
Appreciate your time.
podcast, and thanks for the information.
Appreciate it.